Whatever it is, I'm definitely in.
My first lead surgery.
Shaun! That is awesome!
I am going to rock it.
Oh, hell, here you are!
Esophageal cancer is a serious condition. However, you don't have any remote or metastatic disease and responded well to chemoradiation, so a resection of the esophagus should render you cancer-free.
You look awfully young. I always say the younger they are, the smarter they must be.
We will pull the stomach up and attach it to the remains of your esophagus, keeping your GI system connected so you will not need a permanent feeding tube.
My oncologist told me all this, but I refused to believe it, that it was all gonna be okay until I heard it from my surgeon. I'm sorry. It's just, I've been through a divorce and a career change. And I finally bought my own cafe 3 days before I got my diagnosis. And I thought it was a sign I was making a mistake. But it was just the opposite.
I wasn't done.
I'm sorry.
I have to inform you of the risks of this procedure. There is a 7% chance of heart and lung problems, a 12% chance of infection, a 0.5% chance of death, among others.
Bring it, Dr. Murphy.
She has extensive scar tissue.
And it's plastered her stomach to her anterior abdominal wall.
I told her she wouldn't need a permanent feeding tube, but she will.
We've got to tell a budding chef she'll never eat again.
How will she react?
Don't know. Badly, but the specifics
You should tell her.
She's your patient, it's your job.
I'm bad at patient communication. If I make her very unhappy, she may not want me to do the surgery.
If you're not willing to take that risk, then you should hand the case over to Park.
No, I don't want to hand the case over to Dr. Park.
Park will tell Beth. And Shaun, it's still your surgery.
You had surgery as a child.
As a baby, I don't even remember it.
There's considerable scar tissue, more than we typically expect to find, which has affected our surgical plan.
How?
Dr. Murphy will field that question.
No, Dr. Lim said.
Proceed, Dr. Murphy.
Somebody please tell me.
We can't move your stomach up, so you will need a feeding tube. For the rest of your life. The good news is that this surgery is simpler, so your recovery time will be shorter by 3 to 5 days.
Degrassi lesion to create countertraction. I'm going to separate the mass from the underlying myometrium. Damn it, let's get suction.
The mass has surrounded the uterine arteries.
Can't remove the mass without killing the baby. Dr. Resnick, if you were lead, how would you proceed?
We're already in, so I'd biopsy the mass for testing, then I'd perform an embolization of the arteries feeding the tumor.
Very good. Dr. Park, what does that do?
It should allow us to control the bleeding so we can close her up and leave the baby in place for 2 months. That'll give the baby time to become viable outside the womb. At that point, we go back in, safely take out the baby and the mass.
Sounds like the right call to me. We'll be performing an embolization of the arteries feeding the tumor.
I'll inform Chief Lim.
Not necessary.
It's protocol to run all decisions about complex procedures by the Chief of Surgery.
There's only one clear path, which means there is no decision. Dr. Resnick, please cauterize those bleeders with the argon coagulator. I nicked an artery. She's hemorrhaging. Hang 4 units on the rapid infuser. Give me a vascular clamp. We need better control the bleeding. Clamp off the common iliac.
There's too much blood to see in here.
We have to take the baby out.
Paige, the on-call neonatologist, let them know they're gonna have a 23-week-old girl coming their way very soon.
She's gone into unstable VTAC.
Dr. Resnick, we're gonna need the defibrillator.
Charging. Clear.
Continue compressions.
Give me 1 milligram of epinephrine.
She's gone into VFib. Shock again.
Charging. Clear.
I'm gonna crack her chest. I'm gonna do an open heart massage.
Heart's exposed.
Starting the massage. Internal cardiac paddles.
Charging. Clear.
Again.
Charge. Clear.
Again.
Charge. Clear.
Let's open the uterus and get the baby.